it's 2:10. Welcome to the session called What to Expect After Transplant Surgery. By way of introduction, I'm Patrick Dean. I'm a transplant surgeon at the Mayo Clinic in Rochester, Minnesota. It's really a privilege to be back talking to this group, and maybe some more people will come in, but we'll start. To those of you online as well, this is one of my favorite talks that I've been fortunate enough to give for, I don't know, the last 7 or 8 years at least, every time you guys have had this meeting. Today's a little different. I often talk about kind of getting ready for the transplant and also a little bit longer term kind of things, but today's kind of right in the middle. So there are talks tomorrow on preparing for a kidney transplant. One of the nephrologists from UC Health here in Aurora is giving that talk, and then there's, I think at the same time, there's a talk on longer term things that happen after transplant, and one of my colleagues from Rochester, Naeem Issa, is giving that talk. But this is kind of right in the middle. We'll talk a little bit about getting ready, talk a lot bit about what happens with the transplant, potential issues, your hospitalization, and your early post-transplant recovery, and then a little bit about the first few weeks to months after. But if you're looking for way before or way after, tune in tomorrow. The Slido information is on the screen. We'll show this again. For those of you remote, this is how we'll field most of your questions, but again, we'll show this at the very end as well. I was asked to show this disclaimer slide by the PKD Foundation. You can read through that quickly. And I don't have any particular disclosures to reveal. I will tell you that I'm going to talk generally about what will happen with your kidney transplant. I work at one kidney transplant program. I've been on faculty there 17 years. I know that one pretty well. I don't know everything about all the others, but we're talking general terms. I liken it a bit in, so how long you're in the hospital, what they do with this or that, which drugs they give you. It's a bit like your grandma's pound cake. Everybody thinks theirs is the best, right? But they're all pretty good. But there will be slight differences depending on where you go for a transplant. But in general, it's fairly standardized for the basic things. But that's my main disclosure, is that I know one kidney transplant program really well and am familiar with some others. I'd like to talk today, though, about explaining how you can help prepare for a transplant. Again, not way before, not when your GFR's 50 or 40 or 30, but sort of in the weeks to months preparing for a transplant. We're going to describe the operation that we do for most kidney transplants. We're going to review how people recover from a kidney transplant, and then we'll discuss some of the potential complications as well as kind of the first few weeks after the recovery. So in general, when you get to the point you've thought about transplant, you're going to a transplant center for an evaluation, I think, like anything in life, you tend to come out of things better the better shape you are going into them. And I'm not going to give people a long lecture on fitness, but it is the better shape you are, in physical shape, and mental too, but physical especially, the easier it will be to recover from the operation. So that's why I want you to give yourself some TLC when you're trying to get ready for a transplant. This is a phrase I stole from my wife. Mostly she uses this a lot more in her practice than I do. But increasing your level of physical activity is helpful. Remember, you're going to have a general anesthetic. You're going to be in the hospital. You're going to have discomfort. So we want you to be active as much as you can. We'll talk a bit more about that. The decreased intake of saturated fats, I always have that on there. Just eat kind of a heart healthy diet. Most of you are probably already really good at eating low sodium diets for your blood pressure and things. Tobacco's bad. I don't know if anybody's heard that, but it was talked about in the 1950s. It kind of ebbs and flows. Other substances, depending on where you live, may or may not be legal, but smoking any of those substances is probably not great for you. And then if you do tend to carry a little extra weight, especially around the middle, it's worth at least considering and hopefully trying to lose some weight. Losing weight's a really hard thing to do. The activity doesn't have as much to do with it as you probably think, or as we've been taught historically. Most of it relates to how much we're taking in orally. If about a pound or two a week, though, is really all we're going to ask anybody to lose from a safety standpoint. The crash diets and things don't really work. And for most men, if you eat about 1,500 calories a day, not very much food, but if you eat that, you'll tend to lose a pound or two a week. For women, it's about 1,200 calories, but most women tend to have smaller frames, and that's just the facts. One little caveat, if you're on peritoneal dialysis, many of the dialysate solutions have a fair amount of dextrose or sugar in them. And so they'll give you calories every day when you're doing the exchanges. And sometimes that's 400 to 500 calories a day that needs to be included in that total. So really, really hard on peritoneal dialysis, I think, to lose weight. I'm not a nephrologist. I don't recommend dialysis modalities, but my experience is that people on PD really have a hard time losing weight. And that's all we're going to say about PD. How much physical activity should you get? Depends, but these are just from the CDC. And this is, even folks with chronic health conditions, which I would think PKD and chronic kidney disease would fall in that category, are recommended to get 2.5 hours a week to 5 hours a week of what they call moderate physical activity. And that moderate is walking, briskly, 2.5 to 4 miles an hour, playing doubles tennis, raking the yard. I'm not sure playing golf, riding in a cart is in that category, but a lot of people do that. But just be as active as you can. It'll just help you get better, help you get through the anesthetic better, help you recover better, get your mobility back after the operation. The reasons we ask people to lose weight, it's not so much, although it does in certain cases make the surgery a little bit easier for the person doing it, but it's mostly to decrease things that might happen to you. Things like infections of the incision, where the incision has to be opened up and allowed to heal from the inside. Hernias, patients with polycystic kidney disease are an increased risk for hernia development anyway after surgeries or just without surgery. So that can help decrease the chances of those things happening. About 15 to 20% of patients after a transplant will develop what we call post-transplant diabetes. Some of that's due to medications, some of that's due to excess weight. So the main thing we can control, we control both of those to some degree, but if we try to reduce our excess body weight, that can help with that. And then it decreases the chance of post-transplant medical conditions that you might hear a bit more about tomorrow from Dr. Issa, but things like heart attack, stroke, many cancers are associated with excess weight. So, and these are the main things that kidney transplants become a fairly successful enterprise in the last, 60 years since it's been done. And it's really something that is, most of our patients do fairly well from the kidney transplant standpoint, live long, productive lives, but the heart attacks, strokes, and cancers are what we see people pass away from after a transplant, whether it's 5 years, 15, 20 years after. But these are the population writ large, this is what we see as the major causes of death in our population. So we want to reduce those as much as we can. Other things that maybe aren't talked about as much, if you go to a transplant center, you're going to meet with a lot of people. The people are probably to pay the most attention to, I think. I mean, yeah, be nice to your surgeon, but most people are anyway. But are the social workers and your coordinators. They're your main link and your main guide to get you through the process. Everybody has to meet with a social worker. Everybody has a pre-transplant coordinator. And they're going to help you with a lot of this planning. But things to think about that I think are important is who's going to help look after you. Depending on where you have your transplant, you might be asked to stay there for a few weeks after the transplant. Even if you're having it here in Denver and you live in Aurora, you still need somebody to help look after you a bit. You're not going to need a hotel, but you still need somebody to help. So your caregivers can be very important. It doesn't have to be the same person for the entire time. Some people have a rotation, and that works great. Some people have, sometimes the spouse donates to their spouse, and so then both people are kind of out of the picture for a bit. But think about who might be able to help you. Where are you going to stay? As I mentioned, if you have your transplant at UC Health and you live in Aurora, you don't have to think about that too much. But if you come to Rochester, Minnesota, and you live in Denver, then you have to think about where you're going to stay. A lot of places have kind of hospitality houses for transplant patients. Probably not as many as have hospitality houses for like the Ronald McDonald House for children or for cancer patients, but many programs do have hospitality houses, and many of them have arrangements with local apartments, hotels that give discounted rates for their patients. Airbnbs become very popular if you're going to one of these places where you might need to stay for 2 2 to 3 weeks. That a lot of patients are using that sort of arrangement too in towns with big hospitals. If you're having a living donor transplant, it's a little bit easier to plan for, of course. It's kind of like planning to go on a trip or go to somewhere for a few days to weeks. But if you're waiting on a deceased donor kidney, I like people to have a bag packed. And because the call doesn't happen at 9:30 in the morning usually. For some reason, they're at 2:30 in the morning. And it's always a surprise, and it's always a freak out moment for everybody. And you have to kind of settle in and think, okay, now I've got to go down to my transplant center and get my transplant. And if you have everything kind of ready, it may not have everything you need, but at least have, the basics. Some pajamas for the hospital, some comfortable clothes for when you get out of the hospital, toothbrush, basic supplies, your medicines. Throw those in that bag and come down to the transplant center, and that'll at least get you through the first few days. And also, if you're on the deceased donor waiting list, this is a hard one, but answer your phone. I don't answer my phone most days because unless I see the name and recognize it. So put your transplant center's phone number, ask them what they're going to be calling you from, put it in there as a contact so it shows up. Otherwise, just answer and suck up some spam. It's really frustrating to not be able to get people on the phone, and it happens. People are on the waiting list for several years. You try to call their phone, you try to call their next contact. We usually have 3 or 4 numbers, but just answer your phone, because there are rare instances where if you can't get a hold of that particular person, you have to pass on that kidney for them and go on to the next one. So answer your phone. Answer your phone. Deal with a little spam, or even better, ask your transplant center, what's your number, what's it going to look like, put it in as the contact, and say, and maybe it says in caps, answer this one, because it's important. But you don't want to miss out, and it's a lot easier if you just answer the phone. Talk a little bit about the operation. Generally, for most patients without polycystic kidney disease, we tend to not do much at all with the native kidneys. Polycystic patients have a different kind of presentation and different types of symptoms related to their native kidneys. But even then, in the majority of cases in the United States, the polycystic kidneys stay in. We don't mess with them at all. You can see they're up high here on the upper part of the abdomen. And so we don't even see them necessarily. Big polycystic kidneys you might feel as you're doing a transplant, but we don't really see them or dissect them free or anything. But we tend to make incisions lower down on the abdomen, just depending. And these are just 2 examples of them kind of lower down. And so we work from the front. And then the new kidney is plumbed in to the artery that goes down to your leg. Here it's called the iliac artery, and right next to that, which is convenient for transplant surgeons, is the iliac vein. And then your bladder's right behind your pubic bone, and we just sew the ureter, which is the tube that drains the urine, to the kidney, or to your bladder, rather. This is a little bit more explanation of that. Again, it's really mostly just 3 connections. And so the surgery itself takes anywhere from 2 probably to 3.5 hours, depending on what you're doing, how hard it is. But most of them are probably 2.5 hours to 3, something like that. That's kind of what a new kidney looks like after we've given it its blood supply back. It looks nice and pink and very happy. Most of the living donor kidneys will start making urine right away in the operating room. Some of the deceased donors, as we talk about, they're a bit slow to come out of the gates and take a little while to recover, but ultimately usually will. So the complications of a transplant operation, many of them are the same as any abdominal operation. You're going to have things like infections of the incision or hernias of the incision. We talked about that briefly already. Other things that can happen to folks having, fairly major abdominal surgery in the hospital, things like blood clots in the legs that can go to the lungs. So we make sure people are up and at it, walking around as soon as we can. But a fair number of so those are kind of common to every kind of abdominal surgery. And then there are rare things like getting a pneumonia for being on the ventilator and being in a hospital, really, really uncommon. Irregular heart rhythms, those kind of things can happen, but also very uncommon. But the specific things to the transplant surgery, as I mentioned briefly, it's basically plumbing. And I grew up in Birmingham, Alabama, and at the time, this was a very small plumbing company, but I don't know how you can see it there, but their slogan is, "We repair what your husband fixed." And so I'm certain the wives in the call or in the room can appreciate that. But basically it is, and the reasons you might call a plumber when you need to, because you don't need a plumber most days. And that's kind of how kidney transplant works. Most of the time, you turn the hot water faucet on, hot water comes out, everybody's happy. But the reason you either holler at your husband or you holler at your plumber are clogs or leaks, right? And that's kind of what happens with kidney transplants. Most of the time, they're working fine. But things we do see in the early, meaning first few weeks, or we can see, relate to that plumbing. And so I mentioned we make a connection between the ureter, which is the tube that drains the urine, right to the bladder. Many programs, not every single one, put what we call a stent across that connection that we make, and that's just a little very thin silastic straw that helps keep the urine system open, and that comes out in varying amounts of time, usually via cystoscopy, although sometimes some programs like we do, we attach it to the catheter and it comes out with that. But most programs probably have a stent, but not every single one. The things that can happen with this connection, about 3%, 3 to 4% of the time, there's an issue with the ureter. And that's something that usually requires another surgery to fix, but it's very fixable. Urine can leak where we make that new connection. That's usually a fairly dramatic presentation. You'll have a fair amount of discomfort. It's usually a fairly straightforward surgery to fix, but it's another surgery. The other thing is this ureter can become narrowed anywhere along its course, whether it's at that connection that we make or if it scars up certain ways all along its course. And then it causes obstruction and blockage. So the kidney doesn't like that at all. And if we do ultrasound, sometimes we'll see pools of urine up in the kidney. Call it hydronephrosis is the fancy word. And even sometimes we'll manage that initially by putting a drain tube right into the kidney as kind of a pop-off valve to let the kidney recover, be happy. Then we can inject some dye through it and study where the narrowed area or the blockage might be, and that helps us plan the surgery we would need to do to fix it. But around 3 to 4% of the time, we have a ureter problem. Other things that happen kind of related to the ureter around that area is what we call a lymphocele, which is the fancy term for fluid around your kidney. All of our tissues have a certain amount of fluid in them, and then right now everybody's tissues are kind of all fused together like you developed. We make a space, dissect those tissues out to put the new kidney in, put the kidney in there, and it doesn't always take up every nook and cranny of that space, and so sometimes some fluid builds up. And if that fluid were to build up kind of on top of the kidney here, and it's not bothering you much, and it's definitely not bothering the kidney, we tend to leave it alone, and many times it'll just resorb and go away. But occasionally it builds up in an area that's kind of a tight little area, and it can cause narrowing or compression of that ureter, kind of like you drove over a garden hose with your car tire and you crimps it. And so these we treat with either a drain tube into the fluid collection from the outside to let it get sucked out, or occasionally we have to do a surgery. The name of the surgery is called a peritoneal window. And we open up the peritoneum and allow the fluid to just drain on the inside where it gets reabsorbed. And there's about an 8 to 10% chance of having this kind of thing happen. Maybe a little less, but it's about that much. Leakage from the blood vessels we have a name for, that's called bleeding. The need for blood transfusion depends kind of on where you come to us starting. Many of our patients with CKD4, certainly with CKD5 or those on dialysis, your hemoglobin's running around 10 or 11 is about what we see in clinic, usually the day or two before surgery or when people come in for a deceased donor. So I usually quote people, or at least in my experience, it's about 1 in 10, 1 in 12 to need a blood transfusion, something like that. Less often than that, people need to go back to the operating room real quick to evacuate some of the blood that's accumulated around the kidney or if there's any active or ongoing bleeding. But that's not a very common thing, but can happen. The worst thing that happens with a kidney transplant, unfortunately it's not very common, it's well less than 1% at most of your bigger centers, is what we call thrombosis or clotting of the kidney. And blood either can't get in the artery going to the kidney or can't get out of the vein of the kidney, and then the kidney doesn't work. We try to do everything we can to make our connections between the vessels as good as we can. Then we put the kidney in a position where it's happy and everything looks kind of hunky-dory. Many times we'll do ultrasounds to look at the blood flow, and that's a very good test for that, at looking at blood flow. And occasionally you need to go back to the operating room and reposition things or fix things. And if we get to it early enough and the kidney's not clotted off, It'll often recover. It might be a little slow out of the gates, but it'll often recover. But if we wait too long and have to take it out, it's just no fun for anybody in the whole transplant center, especially the donor who donated to you. If they were a living donor and they're not happy, recipients are not happy when this happens. The coordinators are bummed out, the family members are bummed out, everybody's bummed out, and probably most of all, the surgeon who was involved is most bummed out. But it's just not fun. Fortunately, this day and age, it's fairly uncommon, but not zero. I wish it were zero. If that does happen, you don't lose any waiting time you've accumulated. You just kind of, it's really unfortunate, but it's, yeah, I don't even like talking about it, really. It's just so distasteful, but you need to know about it. Other things that happen after your transplant, I put at the bottom of the slide partly because everybody worries about rejection. Like, you know, and even when I speak to family members right after the surgery, they haven't rejected it. Well, it's hard to reject a kidney in an hour or two. But rejection is a fearful thing, or a frightening thing, but it happens if you look really carefully. We do what we call surveillance biopsies. So we biopsy people at 4 months and a year, even if their creatinine's 1, unless they have a reason not to. But and we see rejections all told about 10 to 15% of the time in the first year. Doesn't mean you're going to lose the kidney to that rejection, but it's worrisome, and we do need to give you some more of the same medicine sometimes, or occasionally a different medicine. A little stronger medicine, but it doesn't mean that you're going to lose the kidney to rejection. Early, meaning the first few years after a kidney transplant, that's a pretty uncommon thing. It was very common. Many folks with PKD had parents, probably even now grandparents or great uncles or that kind of thing transplanted, and that was a big fear. In the 80s and 90s, rejection was a big thing. Still a big thing, but it's less impactful maybe. Still, you have to have some treatment, but it's not. It's a big deal, but it doesn't have to be catastrophic, I guess I'll say. I alluded to it earlier a little bit. There's a thing called what we call delayed graft function, and that's if you need dialysis after a transplant. And this is almost always in the case of a deceased donor kidney transplant. And of course, that usually is for people that were on dialysis before a transplant. Most people, not every single time, but most people that are going into a deceased donor transplant, not on dialysis, which is obviously less common because you have to wait a while, but can happen. They tend to squeak through without any dialysis because we can manage the fluids and things and the chemistries a bit. But with deceased donor transplants, probably, I estimate 30 to 40% of the time we need to do dialysis at least once within the first week. Oftentimes that's for either potassium's too high or just too much extra fluid on board that the kidney hasn't started making a lot of urine yet, even with some diuretics, and so we have to do dialysis. It doesn't mean the kidney's not going to recover. It just means that sometimes we have to do dialysis. Sometimes it's just once. And when you look at rates, national kind of data, if you go to the UNOS or the SRTR website, they define it as even one dialysis in the first 7 days, that's delayed graft function. But sometimes it can last for 2 or 3 weeks, even a month. It doesn't mean the kidney's not going to recover. It just means it's really slow. And so, but it's hard to be patient, hard to keep your spirits up when that's going on. Many times, at least in our practice, if that's going on, we will do a biopsy at some point to make sure that, we're not missing something. This is just, the kidney recovering versus that kidney recovering with a little rejection on top of it that we need to treat. But most of the time we do the biopsy at a week or two, and it's just that it's still recovering. So again, every hospital is a little different, probably every transplant program, but generally this doesn't set you back like a heart surgery as much, or well, even heart surgery these days, open heart surgery, bypass surgery, people are walking the next day. The hospitals have changed a lot, even in my relatively brief career. Everybody used to stay, a week in the hospital after a hernia repair, and now they go home the same day. Transplant's moving that direction, although a little slower. But you get up and move either the afternoon of the surgery, the next day you're up moving around. It's not uncommon to be leaving the hospital after just 2 or 3 nights now. We've had people go home after 1 night. And it's fun, actually, because the hospitals, as you may have heard, hospitals are kind of crowded right now and very short-staffed. So one of the impetuses of that is to people that don't really need to be in the hospital, they can leave the hospital. But we don't kick anybody out before they're ready, but it's pretty normal for people to be ready after 2 or 3 nights. Even after a deceased donor, when we need to do that dialysis, that can still be arranged as an outpatient, because that's many times the way people came in, they were doing dialysis as an outpatient or at home, that sort of thing. I will say, generally, if you're on peritoneal dialysis going into a transplant and you have this delayed graft function, it's difficult to do peritoneal dialysis shortly after a transplant because you have a fresh incision. Nobody likes having that abdomen distended, so it might mean a brief period of time of hemodialysis with a catheter in the neck, usually, if you didn't come with an access in the arm. So the other important things that happen in the hospital are pain control. There are a lot of ways to manage pain now, a lot of what we call adjuncts. So there's injections in the preoperatively, there's long-acting local anesthetics we can use. So the pain's much better than it was, say, 10 years ago, I think, at least we've noticed in our practice. People used to be in the hospital with, pumps and IV pain medication. It's pretty uncommon now, at least at our place. And so most people go home with a handful of oral narcotics, and that's about it. The other thing that's really important looking after your transplant is you're going to be on a bunch of different medications. So you're going to come in on 5, 6-ish, somewhere in there, sometimes 3, sometimes 10. You're going to come in on one batch of medicines. You're going to leave the hospital on a totally different batch of medicines. Some of them might be the same, some of the blood pressure medicines, that kind of thing. But you're going to have a whole new group of rejection medicines. Most places will have you on some antiviral medications, sometimes antibacterial agents to help prevent urinary infections and some other things. So you're going to have a whole new batch of medicines to learn. You don't have to know the molecular structure or how these drugs work when you leave the hospital, but it is important to know what they're for and when to take them. The nice thing, too, is that we're not kicking you out. If you come to Rochester, you're not going to get a transplant and go back to Alaska the next day. We also have time in clinic to work on that, too. And you get a lot of education in the post-transplant clinic about this. The pharmacists will see you. Pharmacists see you in the hospital, too, but they'll see you. The social workers will see you handle things. So you're not going to be on your own. You just kind of, one of our program in Arizona calls it kind of survival skills. Can I get through a couple of days on my own? And I know what to look for, and I know what meds to take, and then I'll be okay. The other thing, sometimes you leave with a catheter in the bladder. Nobody likes this, especially dudes. But it is, the reason the catheter's in the bladder is to keep things decompressed. And so we made a fresh connection usually to that bladder, and we don't want it to have that leak if we can avoid it. And one way to do that is to keep it from getting, distended or blown up like a balloon, and then stretching that new connection we make. And so it's a few days with a catheter. It's anywhere usually from 3 days, typically where we are, to a week or so, depending on also how your bladder looks. Sometimes people's bladders don't look as good as other bladders, and they might be a little thinner or a little less substantial, and we might just elect to leave it in longer. But you can certainly leave the hospital with it. Very common in other urologic type procedures like prostate surgery. People run around with a catheter for a week or 2 sometimes. So it's less than that, but I know it's no fun. Nobody cares for it, but we don't leave them in too terribly long. And then most times you'll be seen in what we call a post-transplant clinic, and every hospital is going to have a little different arrangement for this. Ours happens to be up on the same floor. We work with the pre-transplant patients, post-transplant patients around the corner from our hospital. We're fortunate that way. But the main goals of that, and I say 1 to 3 weeks because, again, it depends on how close you live to the transplant center, what your resources are like, how the kidney's working, how you're doing overall. But it's about 1 to 3 weeks in that clinic, mainly to keep a good eye on your kidney function. Also, sometimes we adjust we check levels on certain immunosuppressive drugs. You might have heard of drugs called like Prograf or tacrolimus. That's a very common one in kidney transplant. We check the levels, and because we don't want it to be too high, we don't want it to be too low. We want it to kind of be just right, and that can take a little fiddling depending on your metabolism of drugs, also on what other drugs you're on, and a variety of things. So we keep a good eye on that. We want your blood pressure to be really well controlled. The first couple of days you leave the hospital, we'd probably rather have you a little high than low. But then we take the next week or 2 to 3 to kind of fine-tune that and make it where it's nice and stable, safe for you, safe for the new kidney as you leave and go back to your normal lives. But that's the main reason of clinic. Many times the stent comes out or around during that time. Most of the time that's done with an outpatient urology procedure. You go to the urologist, they put a scope into the bladder, grab that stent. Also, not the most fun thing for most patients, especially men, but most have lived through it. And then we're also looking for, we're monitoring that kidney function, but we're also checking your incision, checking other things to make sure that you're not developing any complications. And if you are, we try to recognize them as early as we can so that we can deal with them. Sometimes that means, an ultrasound in the clinic, that kind of thing, just to look at how the kidney looks and what might be around it. Ultrasound's kind of just like in the, many of you probably had ultrasounds for your polycystic kidneys. It's a very good kind of non-invasive, no x-rays, no radiation, nice way to look at kidneys, actually. Gives us a really good idea what's going on. As I mentioned, you're going to get ongoing education, the pharmacists, the coordinators, the social workers, your nephrology team. Hopefully you're not seeing your surgical team a lot. That's probably a good thing for you, but we're there if we need you. But they're really trying to get you ready to go home, wherever that home is, if it's across the street from the center or if it's across the country. Establishing, most patients probably come with most patients we see have a nephrologist when they got to us, but that, excuse me, that nephrologist may or may not want to take care of post-transplant kind of issues. Their comfort with that and their training is variable sometimes. And so we definitely want you to make sure you have a good primary care doctor, because post-transplant patients still need all the same stuff everybody else does. You got to get your colonoscopy every so often. You got to get your health maintenance things for females, pap smears, mammograms. All those things don't go away just because you had a transplant. But that's what we're trying to do in the post-transplant clinic and really try to get you back to be as successful as you can at home. Probably most places in the first few weeks have some random lifting restriction that's something like 10 pounds for the first 6 weeks, like a gallon of milk is about 9 pounds. So just so and that's just till things heal up. It's not going to destroy or wreck the kidney by lifting stuff. It's mostly so your abdominal wall heals up and reduces the chance of hernia. But that's a pretty standard thing. Dietary restrictions many times just go away, which is really cool for patients because you've been asked to not eat this, not eat that, eat only this much of that. And now we say, well, your kidney's working great. Eat whatever you want. Occasionally, we have to monitor some of the other drugs interact with the way potassium gets excreted in the body, and we ask you to kind of minimize potatoes, tomatoes, bananas, those kind of things for a few weeks just till we get things tightened up. But long term, that's usually not an issue. The patients that have delayed graft function usually need to be on, kind of stay on the same kind of diet we were before a transplant. Avoid the phosphorus, avoid the potassium until the kidney's really working nicely for those few weeks. But the thing I do counsel patients to do is now that you can eat everything, watch out because it all tastes really good now. And food didn't taste good before a transplant many times, and now it tastes great. So just be a little judicious and watch out for gaining weight after a transplant. I think gradually people's energy levels will return. It's not a week after necessarily. You'll be a little bit run down, and you have kind of good days and bad days. I used to have kind of an escalator slide in here. It's, you kind of go up the escalator, you might stop on a step, but you're still moving overall in the general upward trajectory. But you'll have a day where you feel great. You might overdo it a little bit. The next day you hurt more, you feel wiped out. But certainly by 2 to 3 months, most people are doing pretty much what they want to do. You're going to have regular blood work done, often monitored by your transplant center, usually not your primary doctor, unless your primary nephrologist really wants to do it, and that's fine. And then the transplant-related things that come up down the road, we still interact with patients that are 20 years out after a transplant. Not so much for primary care or health maintenance type things, but anything related to the transplant. And as I mentioned, it's really important to have good relationships with your local team. And I'll leave you with this. It's the Navy SEALs have shortened this, and they say no plan survives first contact. And so we can plan all we want, but things still happen. But it does help to have at least a plan and going into a transplant or any kind of major healthcare decision that you have to face. But again, it's not always perfect, that plan, but at least you've thought about it. With that, I will leave you with the Slido slide, I suppose. My contact information's here. I'm happy to give it to folks afterwards as well. Feel free to reach out. Always like to get contacted by the PKD Foundation folks. And there's the final Slido slide and the final slide period, I think. So we'll take any questions you might have, and thanks again, really.
Okay, so the first question we have is, can post-transplant drugs be taken in liquid form for a person who has trouble swallowing pills?
And just to repeat that, the question is, can post-transplant drugs be taken in liquid form for those that have issues with pills? Many can. The pharmaceutical companies are pretty good about, I can't promise that every single one is, but most of our commonly used things either have a liquid kind of form. Prograf actually has a sublingual, meaning under the tongue form, that can be used. So yeah, we can usually, and certainly, you know, kids that get transplanted, that's very common. So it's generally pretty doable. Every single one might not be there, but there are certainly choices that are.
Can you elaborate on why rejection is less of a concern now than it used to be?
So the short answer is the drugs are better. We don't emphasize tissue matching it nearly like as much as we used to, say, in the 80s or 90s. But the drugs are much more effective than they used to be, both for preventing rejection and also for treating the rejection, I think. So that's probably why, again, people aren't going to lose their kidney just because you have rejection necessarily. Those are all the online. Any questions from here in the room? We have a microphone that we'll bring out to you if you like.
Yeah, hi. Thanks for the presentation, Doctor. I was wondering if you had I'd rather have a patient do this or that. I mean, if they had a choice of staying at home after the transplant, if they're an hour drive from the center, or getting an Airbnb across the street. I mean, there's a value, right, in staying home or being close by.
Yeah, I think if you're, my general preference for that, if you're within like half an hour, I would just stay at home. Or I think that's fine. For the first week or so, if you're an hour out or 2 hours, I mean, for where our geography, we transplant some people that live in Minneapolis, St. Paul, and that's about 75 miles from where we are. Those folks, generally for the first week or so out of the hospital, will stay close to home, or close to the center, rather. But then as your visits, usually the visits will space out a little bit the farther you get out from the transplant. So if you want to go home for 3 or 4 days, then come back, that's probably fine. So I think it kind of depends on, certainly what your providers want to do, what you want to do. But if it's nice the first few days to be a little closer, I think, just in case something dramatic happens, which usually doesn't, but at least that's, an hour gets to be a bit of a drive to come over for a blood draw at 7 or 8 in the morning, and then, so it just, but as the appointments space out, then I think people can generally get, a little farther from the centers.
Could you talk about anti-rejection regimens that use prednisone versus ones that don't use prednisone?
Yeah, so around 10, I don't know, maybe 15 years ago, there was a big push across the country to go to steroid-free regimens. They work for many patients. I would say where we are, about half our patients are on a steroid-free regimen, meaning everybody, at least in our practice, gets a bit of steroid up front for the first few days and then go off. But potential advantages are, the results are basically the same in the bigger trials and even some of the registry data with the UNOS and sort of data. They're fairly similar results, I would say. A lot of it comes down to preference. Most regimens that require people to stay on steroids have people on like 5 milligrams a day at the lowest as things get out. That's not a lot of prednisone. It's hard to blame too many issues on that much, but probably bone health is an important thing, osteoporosis, that kind of thing. If you compare people off steroids versus those that are on them long term. Weight gain, when we've looked at it, it hasn't been any different actually between the two regimens, because 5 milligrams is really less than your body makes in a day. So I don't have a strong opinion one way or the other, but about half of our patients are off of steroids after the first few weeks. That gets back to that pound cake recipe a little bit, though. Certain centers, they want everybody off steroids because they're the bane of our existence, and everybody on steroids is falling apart. So, but good question.
Hi, sorry again. I want to wrap my arms around the complications percentages that you presented.
Yeah.
And, you had multiple complications and
Yeah.
various percentages associated with them. Is it, in general, certain people get multiple complications, and for the most part, very few
I do-
people get any?
Yeah, one of my mentors and partners, he has a saying that he said 10% of the patients have 90% of the complications. And there's probably a little bit of truth to that. But I don't think, most patients don't have an incisional problem, a urine problem, fluid collection and rejection, and then nobody else has any. But, I think the takeaway message is most of the time it goes very well, and most of the complications other than, clotting of the kidney, everything can be fixed generally. And it's no fun probably to go through it on the patient side. It's often no fun to go through it on the surgeon side, but most of the time I think people look back, and when I see people a few years out, they're like, "Oh, remember you had to reoperate on me for bleeding?" Well, no, I don't, but sorry I had to do that, but you look great, so it's I think that's kind of the perspective I would take going into it, is that most of the time it works pretty well. Most of the things are fairly manageable and don't have a huge impact on the long-term kidney function, which is really the result that everybody wants, right, is a kidney that works for the next 25 years. But yeah, that's most of the time, see people in clinic before they're going home and they haven't had any of those. So it's.
Just getting back to the steroid question again. Do most PKD patients, do they tend to go home on more steroid-free regimens because they tend to do better versus, say, with other types of transplants for other types of reasons?
Really good question, insightful question. And you're right, patients in general with PKD do better after a transplant because they tend to be healthier going into a transplant. You have this conference is all about people that have a kidney problem and other problems, but your kidneys don't have a problem because you have heart disease and type 2 diabetes, for example, and sick all over. At least in our practice, the decision to use steroids or not is not based on how healthy a person is so much as what we think their risk of a rejection, that sort of thing is, or in certain diseases, the chance of, which isn't PKD, is not one, but the risk of a disease coming back in a new kidney. Patients that have a lot of antibodies against tissue types from prior transplants, prior blood transfusions or pregnancies are the main reasons. We tend to be a little more favorable for steroids. So we base it more on their immunologic profile than we do on just, some of it relates in some programs, how heavy-handed we are with immunosuppression up front also. There's sort of two main classes of those drugs. One really depletes a lot of your white blood cells. The other main category doesn't. So we tend, if we give the patients one that doesn't really knock their immune system down too much, then we tend to give them steroids because we didn't knock the immune system down so much. Again, it's a recipe sort of and a preference kind of thing, but I would say on average, most patients with PKD in our institution, under the age of 65, for example, would go home without steroids. And the number 65 is just a random cutoff, too, because age is completely relative. But, although the immune system is different as you age, so. Yeah. Oh, very good question.
I think we have time for one more.
Great.
Realizing that Prograf and Cellcept are usually the cocktail in prednisone, are you seeing any research in development of alternative anti-rejections?
And yeah, there have been. I mean, everybody wants an immunosuppression drug that has zero side effects, which will never happen, and isn't nephrotoxic or toxic to the new kidney, which may happen. And that's been sort of the holy grail of anti-rejection drugs for a long time. There are alternatives. There's a drug called sirolimus, or its cousin everolimus, that are used sometimes. They're not perfect. They have a different side effect protocol. There's a relatively recent drug that came out that's in a monthly injection called belatacept that's usually used in conjunction with, sometimes with, almost always with Cellcept, but sometimes with Prograf and Cellcept, but at lower doses to help minimize the exposure or the problems related to those. But so there are a few new drugs out. And there are always some in the pipeline, but those are the most recent ones that have come out. Belatacept can be a good option for some patients. The nice thing about it, it's once a month, but the downside about it, it's once a month because you have to go get it once a month. It's an infusion. It's good for people, actually, you're worried about taking their medicines on a daily basis because some people struggle with that. Medicines are hard to take, period, but certain people struggle more than others taking their medicines, even after a transplant. But there are some alternatives, and again, that kind of gets back, most programs will have kind of a menu, might be a word for it, but based on where, your particular profile fits in their algorithm, what you might be eligible for in that. So yeah, definitely a good question to ask. Because it's not, none of these are really these recipes are written in stone either. And so they can be modified a bit. And we do modify them, that many people's Cellcept dose is decreased by the first few months because they don't tolerate it terribly well. You can switch over to another cousin of Cellcept that ends up looking like Cellcept after it goes through the GI tract, but has a few fewer side effects. So you stay involved with that and work with your team to figure out what works best for you. None of them are perfect, though. I think Dr. Issa is going to talk a bit about that tomorrow if you're interested. But, so kind of I'll let him do the less fun part of the talks with the side effects of drugs because there are many, but everybody doesn't get all the side effects. To go to your question, kind of related to the operation, everybody doesn't have every single side effect that's on the piece of paper that comes with your pills, right? I mean, that list of things that might happen is a page and a half long, usually in very small print, but most of the time it's one particular issue related to the medicine that makes it where you're not able to tolerate it particularly well. So, well, thank you guys again, and those of you online, thanks very much. Again, it's my pleasure to be here.